All right. So my presentation is on the neurophysiological effect of manual therapy. I just handed out a little overview, which you can take a look at throughout, but I'll touch on most of those points. So first, need to find out like the three different ideas behind what manual therapy, the effects that could be going on. So that's the biomechanical approach, the general neurophysiological approach, and the specific neurophysiological approach. So the biomechanical effect. The biomechanical effect is kind of the foundational idea of why we use manual therapy as a PT intervention. That is, things aren't moving or they're sore, things like that, and you get those joints moving, and that returns to normal function. So biomechanical force is an application of a mechanical force to alter the mechanics of a biological system. So from the biomechanical approach, things can either be joint biased, tissue biased, or nerve biased. And they all have their own unique properties and supporting evidence. The reason to move away from solely the biomechanical approach is there is some limitations that are found with looking strictly from a biomechanical aspect. Some of those limitations include palpation for position and movement faults, have questionable reliability between raters and intra-raters. The techniques are not as specific as we would hope. Nerve biases cannot isolate one nerve. If you are putting a nerve on tension and you're trying to mobilize it, you're going to be mobilizing the whole system since it's all connected. Forces for joint biases dissipate over larger areas. Specifically in the spine, you're not going to be able to direct your force at one vertebrae. It's been shown that there's a dissipation of the force at least one vertebrae above and below the vertebrae you are targeting. Additionally, studies have reported improvements in impairments away from the site of the application. So a good example is using a thoracic thrust to affect the lateral epicondyle. And so this is not an area that's directly dermatologically related. So there has to be something else going on besides a strict biomechanical effect. The general or non-specific neurophysiological effect can also be considered the placebo effect or an expectation effect. And it plays a role in all therapeutic interventions, but typically is seen most prominent in ones that are manual. It should be considered when addressing patients and describing interventions, and this is for any interventions. This isn't the direct purpose of this literature review. I focus more on the specific mechanisms, specific neurophysiological mechanisms. But if you're looking for any further information, this article here, Individual Expectation, an Overlooked but Pertinent Factor in the Treatment of Musculoskeletal Pain, gives a good broad understanding. So the primary purpose is the specific neurophysiological mechanisms. And it's broken down into three parts: the peripheral mechanism, the spinal mechanism, and the supraspinal mechanism. So from a peripheral standpoint, it's thought that inflammatory mediators and peripheral nociceptors interact in response to an injury, and manual therapy can alter this response. Studies have shown that there's a reduction in blood and serum cytokines, changes in blood levels of endorphins, serotonin, and anandamides, and also shown to alter inflammation and the presence of substance P. And this is all occurring at the peripheral site. So if the application is to the elbow, that's where the changes are occurring. The spinal and supraspinal mechanisms are more the topic of this presentation, and they work around the following two theories. Manual therapy affects the spinal cord by acting as a counter-irritant, which modulates the pain. And it's also suggested that manual therapy bombards the central nervous system with proprioceptive input from the muscles. Both of these theories work around the gait control theory set forth by Melzack and Wall, and are associated with outcomes of hypoalgesia, afferent discharge, motor neuron pool activity, and changes in muscle activity. So this picture is a picture of Melzack and Wall's gait control. So chronic pain or subacute pain that's kind of persistent and continuing on and on, not that first jolt of pain, travels on C fibers. And they're large diameter non-myelinated fibers. And so they fire at a slower rate. So it's a consistent kind of like throbbing. That's where you get that throbbing pain. It's just a signal, signal, signal. And that goes to the spinal cord, specifically the dorsal horn, where they interact with the transmission cells which creates excitation and sends that up to the supraspinal areas, the brain, the control, the perception of the pain. So by applying a manual force, that application will travel on the A beta and A alpha fibers and interact with that G cell. The G cell is the gating cell. And so by causing excitation of the gating cell, it will inhibit the transmission of the C fiber, the rate at which it's transmitting to the transmission cell. So there'll be less signaling sent to the brain, so there'll be a reduction in the perception of pain. The supraspinal mechanism. The supraspinal structures that play a role in modulation of pain include the anterior cingulate cortex, the amygdala, the perioductal gray, the ventral medial medulla. And animal studies have shown that there's a decrease in activation of the supraspinal regions post-manual therapy. So the input from the spinal cord, those signals going up, will alter the occurrence of, or the amount of firing that's going on in these supraspinal regions, which decreases the perception of pain. This model accounts for autonomic responses and opioid responses. And autonomic responses typically are associated with changes in skin conductance and changes in pain pressure threshold. So I'm going to go through a couple articles that give evidence supporting the neurophysiological approach and also discuss the temporal aspect of it. So the first is kind of one of the more foundational pieces that's talking about the move away from the solely biomechanical approach to a comprehensive model that involves neurophysiological approach. And so it's paradigm shift in manual therapy, evidence for central nervous system, a component in the response of passive cervical joint mobilization. It's done by Schmidt et al. It's a systematic review assessing the consistency of evidence in the involvement of supraspinal system and mediating effects of passive joint mobilizations. So they were looking at studies that specifically looked at a neurophysiological effect. So if it was looking solely at the biomechanical effect, they weren't included in this study. And if they found 5 or more that were had consistent measures, they then pooled those to have a little bit of a meta-analysis. And they had pretty good methodological studies included. So what they found was concurrent hypoalgesia, sympathetic nervous system excitation, blood pressure increases, heart rate increases, and motor function changes. The 3 measures that they found enough consistency to be pooled were skin conductance, pain pressure threshold, and upper limb neurodynamic test. And so these are the differences of that meta-analysis between the interventions and the controls. So looking through all the data, they came up with that manual therapy has a capability of creating a 20% change in pain-related measures. And the pain-related measures are, in this study, were pain pressure threshold and also perceived pain, so the rating scale pain, the 0 to 10. So there was compelling evidence that cervical mobilizations have a hypoalgesic effect, the activation of the sympathetic nervous system. And they get this conclusion from the fact that there's a concurrent sympathetic nervous system change with the skin conductance and the changes in the pain pressure threshold. Motor function was not improved in studies where they were studying asymptomatic individuals, only when there was a dysfunction secondary to pain. And the widespread effects outside the specific treated areas were compelling evidence for the supraspinal effect as opposed to strictly spinal. So if it's a global change, specifically with the skin conductance and pain pressure threshold away from the site of application, there's something that has to be going on outside of specifically the spinal region. So this next systematic review was looking at the temporal effect of the high velocity, low amplitude thrust. And they wanted to see how long this neurophysiological effect was going to last. And so they looked at studies that focused on the immediate effect and also that looked at a little bit of follow-up. So they needed to look beyond, the studies they looked at needed to be beyond the 10-minute follow-up that other studies had been performing. So they found 5 relevant articles. 3 were 30-minute follow-up, 1 was a 5-hour, and 1 was a 1-week post-intervention. And all of these were strictly this single session of high velocity, low amplitude thrust. And so of all the studies they looked at, they all had the immediate effect. And that's kind of consistent throughout all the studies, that there's a change in this pain pressure threshold and change in perceived pain, but they weren't sure of how long this change lasts. And so only 3 of the studies showed a reduction at their follow-up, and only 1 reaching the MCID at follow-up.